When I was in medical training, I was taking care of a young boy who had been diagnosed with leukemia. And part of leukemia treatment, you get 3 years of chemotherapy. And unfortunately for this boy, he went through all 3 years and then had the leukemia come back. And when that happens, we need to give chemotherapy again, and then give radiation and chemotherapy and give a bone marrow transplant. And so he went through all of that, did the bone marrow transplant, and then a couple of months later, his leukemia came back again. And so the second time, fewer options for him, and his expected survival is only about 20%. And so despite, having the ability to give him high-intensity chemotherapy and going through another transplant, his chance of living would only be about 1 in 5. And so his family was referred to participate in a clinical trial that uses something called CAR T cells. So I'm going to talk about what that is on the next slide, but he packed up his bags with his family. They went to a different city to participate in this clinical trial, and he got the treatment one time, one IV infusion, and we checked a month after he had it, and he didn't have any disease. And then now, years later, he's still alive, disease-free. And this is something that, it made me, didn't expect it emotional, but this is something that made me get really passionate about CAR T-cell therapy and what made me pursue it as a career in research and what I do clinically. I just want to give you context of what the tools we have are in the fight against cancer. Everyone's heard of chemotherapy, radiation, surgery. These are things that we've used for over the half century in treating cancer, but more recently, in the past 2 decades, we've really expanded our options in terms of targeted therapies, which are therapies that are used to target a specific genetic change in cancer cells, or immunotherapy, which is using the immune system to treat cancer. And CAR T cells are a type of immune therapy. The reason this is so important, especially for young patients, but really for everyone, is that chemotherapy and radiation are general therapies. They affect all rapidly dividing cells, and they can have late side effects. And so for children who are going to be living for a long time, we hope, after giving them these treatments, we want to use as targeted of therapies as possible so that they can live healthy lives without any organ toxicities or any issues with cognition or fertility, which can sometimes happen with the other two. CAR T cells, so this stands for chimeric antigen receptor T cell. And this is a treatment that is a living drug. So and it's made out of your own immune system. In order to make this drug, we actually have to take cells from a patient and have them get genetically modified in a lab outside of the body. And when they're in the lab, they grow the cells to millions of cells, and then they're stored until the patient's ready to use them. And then when the patient is ready to use them, they're given back, and in the body, they look for cancer cells. They divide up to 1,000 times, so they're living and growing inside of the body. And in the picture, you can see that the cell is in red, kind of killing this blue cancer cell. And the cool thing about it is that once it kills a cell, unlike a bumblebee that stings you and then dies immediately after, these cells can go on living and killing other cancer cells. And the first person, a pediatric patient who was ever infused, was infused 11 years ago and still has detectable CAR T cells in her blood. So why is this therapy so cool? I mean, aside from what I just described, which I think is really cool. But for the patients like the one that I described in the beginning, they had a survival of 20%, like I mentioned, but their cure rates are now 90% for getting into a remission. And this was really groundbreaking finding when it was first discovered. It led to the FDA giving it a breakthrough designation, and it's now FDA approved since 2017, so it could be used commercially. Yeah. I think one of the things that's important about this to recognize is that the side effects are completely different, and we always have to think about what side effects you could potentially see from these therapies. So it's doing a huge job, and as it's doing that, some of the things that we see can be a little bit scary. So when CAR T cells go in the body, they get activated, they divide, and unlike with chemotherapy and radiation, that's more of you give it, it can cause some nausea, it can cause low blood counts and other side effects. The side effects from CAR T cells are all related to the immune system being activated. So has anyone had the flu or a bad cold? So muscle aches, headaches, fevers, chills, these are all things that are things your immune system is causing. So when you have the flu, it's not necessarily the virus that's making you sick, it's your immune response to the virus. And that immune response is clearly very important because you want the virus to be gone, and it needs to do that work in order to get rid of the virus. But in the case of leukemia or lymphoma, when we're using the immune system to get rid of that leukemia or lymphoma, the immune system has to work very, very hard. And so you can feel like you have the flu, and it might feel only that way in the mild end of things. But when you have a lot of leukemia or a lot of lymphoma, you can get even worse side effects where you need to be in the intensive care unit or need a breathing tube or dialysis. It's possible that it can cause seizures. In the most severe cases, death can even occur from the toxicity from the therapy. So just to tell a story about this, when I was in training, there was a patient who had quite a bit of leukemia in his bone marrow. It was almost fully filled with leukemia. It goes up to 100%. He was at 95%. And so he got these CAR T cells, and within days, he needed to be transferred to the intensive care unit. He had to have a breathing tube. He was put on dialysis. He was getting steroids and a bunch of different treatments to help him get through this. And he was in a medically induced coma. And then when he was waking up from the coma, he didn't recognize his parents. He was having hallucinations. And it was just a very traumatic experience for him and his family. And fortunately, he got through it and he survived, and his disease was gone at the end of the month and remained gone. But he needed to be in the hospital for a month after he got that toxicity. And so that's what got me interested in preventing those severe side effects of this therapy. Since we've started to use this more after it's gotten FDA approved, we've learned a lot more about who is at risk of getting those severe side effects. So as I mentioned earlier, that patient had a lot of leukemia coming in. Not everyone does who's coming into CAR T. They might only have a small amount of disease. But the patients that do have a lot of leukemia coming in are the most at risk of having these severe side effects. So on the next slide is a graph showing that people who have over 5% disease in the bone marrow have about a 40% chance of going to the intensive care unit as part of their CAR T cell treatment. But if you have under 5% disease, you have a less than 10% chance of needing to go. So the group with higher disease burden is the group we really want to target and make this therapy safer for. And in adults, they've started to look at preventative therapies to help prevent some of the more severe side effects by using drugs used for autoimmune diseases. So these are medicines that block cytokines or pro-inflammatory signals in the body. And they've shown some promising results showing that if you give it early on after the CAR T cells, it can prevent someone from getting severely ill afterwards. But these are all adult studies. None of these have been done in children with leukemia. And as we often say in pediatrics, children are not little adults, so we need to study in children. And the other thing is adults that get CAR T cells get it for lymphoma, not leukemia, so we also have to study it in leukemia. Children also have higher rates of severe toxicities than adults do, so it's even more important in children than it is, I think, in adults because of that increased risk that they have. And so this is a knowledge gap that I wanted to address, and my goal is really just to make CAR T cells safer and more tolerable for children and young adults. And I want to illustrate a case. So on the next slide, there's a patient that was referred for CAR T that I helped to take care of. This was a young girl who went through chemotherapy treatment for her leukemia and unfortunately developed a very severe complication of having a stroke caused by a bleed inside of her brain. And this happened in the first cycle of chemotherapy. She lost the ability to walk. And at the end of the month, the worst part was that her leukemia was not in remission. She still had quite a bit of disease after the chemotherapy, so it didn't work. And she was then referred to CAR T cells. And as a provider, I was very concerned because not only did she have a lot of disease, but she also had this history of a severe complication. And CAR T cells, when they make you very sick, can worsen the risk of bleeding. And so I talked with the family about the risk that she would experience and the evidence that we have in adult trials that has shown it's safe to use this anti-cytokine medicine called anakinra. And they agreed that we should do this because of her increased risk. And so what we did was give her CAR T cells, started anakinra, this anti-cytokine medicine, as soon as she developed a fever after the CAR T cells. And she was able to leave the hospital just after a week after the CAR T cell infusion. She never went to the ICU. She didn't have any worsened bleeding, and she was in remission at the end of the month and remains in remission today and better. She's able to walk. She's got her development back on track. So this sort of experience and the experience in the adult trials is what led us to sort of open a trial at Lurie, doing something similar for other patients that have high disease burden. So on the next slide is showing the study schema. So what we're doing is patients are getting the CAR T cell infusion. As soon as they develop first signs of having these adverse effects of the CAR T cells with fever, we start anakinra. And as soon as they stop, we continue the anakinra for another day, and then we stop the anakinra. And that medicine is really helping to block some of the signals that are being spit off by the CAR T cells. This clinical trial, when it's completed, will provide evidence either for or against using this drug. And if it is supportive of it being effective, it could be used for children with high disease burden across the globe. So we're hopeful that we'll be able to enroll a good amount of patients and demonstrate that so that we can make CAR T cells safer for everyone getting them. This clinical trial is supported by the New Cats Foundation, this New Cats K-12 grant. I think that's going to pop up. And I just want to say on the next slide, if anyone has any questions about children's cancer research or preventing these severe toxicities of CAR T cells, to reach out. And then, of course, happy to answer any questions.